housed at Imperial College since 2006, but since 2017, it has been directed by Professor Ian McNeish. Bob Brown has been involved in the centre since its inception, I think, and I came along around about 2009 when I joined Imperial College and started working there. John Krell is another investigator. He works on some ovarian cancer action funded research called Progress, which is looking at understanding genetic risk for ovarian cancer and how we might use that information. And then we have some other investigators that work within the centre that aren't directly funded by OCA, but they're Christina Fatopoulou and Sadaf, who are both surgeons. We've got Hector Kuhn, who works on metabolomics. Paula Cunha is a research fellow that works with Christina Fatopoulou, trying to understand heterogeneity and why different ovarian cancers are different. And Andrea Rockall also works there, working particularly on imaging and how we can use that to better understand and treat ovarian cancer patients. So why are we here? Why are we studying ovarian cancer? One of the main reasons, it's a really difficult cancer to treat. It's not terribly common compared to some of the other cancers like breast cancer, colon cancer. There's about 7,000 cases in the UK each year, but the survival of these patients is quite low in comparison to some of those other cancers. And one of the reasons that is patients often get diagnosed late. And it's when they're at the late stage where the treatment options become more limited and survival is less good. One of the reasons that diagnosis is late is often because of the vague symptoms. People don't recognize these as ovarian cancer symptoms and perhaps don't get referred into cancer clinics quickly enough. And so my research is really about trying to understand prevention. If we can stop people from getting cancer in the first place, I think we'll have a much bigger impact on the outcomes for these patients. Of course, one of the challenges there is obviously if they don't get the cancer and we've prevented it, then they'll never have known that they would have had it in the first place. So prevention is kind of a tricky topic to convince people to fund. And that's one of the things that's great about OCA, and they've taken a punt on funding this type of research. So, I should have reset this. This is another question on Mentimeter for you. What percentage of women get ovarian cancer? Do you know? Let's see if you can answer that. And by the power of crowdsourced information, I hope we'll get to the final answer. Don't be confused by that test run there. "17 people. Give it another second or so. Okay, so that's a very interesting distribution. We've got some people that think it's around about 1 to 2%, some people 3 to 4%, somebody thinks it's up to 10%. I guess you need to put this in context that breast cancer, for instance, it's about 1 in 8 women will get breast cancer, so that's about 12%. Ovarian cancer is not as common as breast cancer, and in fact, the answer is somewhere around 2%. So we're slightly overestimating it here. This just represents that, and when we talk about risk, we often talk about either absolute risk or relative risk, and we'll talk here about absolute risk. So what that means is that around about 2 out of every 100 women will get ovarian cancer. So the incidence is around about 2% during their lifetime. When we think about ovarian cancer risk factors, and I'll talk about one in particular here, which is endometriosis, it's one of the biggest risk factors, non-genetic risk factors that we know about. And if we looked at 100 women that have had endometriosis, then 3 out of 100 women, of those 100 women will get ovarian cancer. So it does increase their risk from 2% to 3%, but you can appreciate that it's not a really big change in their absolute risk. In comparison to that, if we look at someone with a BRCA1 mutation, we know this is a really big risk factor for ovarian cancer. And around about 44 out of every 100 women who've also got a BRCA1 mutation will get ovarian cancer. So you can see it makes a really big difference when you've got mutations in BRCA1 or the BRCA2 gene as well. It's slightly different numbers for the BRCA2 gene. So when we put that in context then of all of the ovarian cancer risk factors that we know about that can inform our risk prediction models when we're trying to inform somebody of their risk. This is a slide here. I'm sorry, it's a bit small, but this gives you an idea of some of the risk factors that we consider to be important in these risk models. So first of all, first degree relative. If you've got a first degree relative with ovarian cancer, then that puts you at a 1.5 times more risk. Endometriosis, I showed you before what that does to your absolute risk. That's, as I said, one of the bigger risk factors that we know about. We've got something called polygenic risk scores. This is looking at common genetic traits. There's a lot of work that's been going on over the last 10 to 15 years trying to understand the genetic contribution to ovarian cancer. And that is a fairly large risk factor in comparison to things like HRT use, which we know if you use HRT, that can increase your risk. Again, it's only a small increase in risk. Height, we know if you're higher or taller than 1.7 meters, that means you're at an elevated risk compared to people who are less than that. If your BMI is above 35, that's quite high BMI, your risk is elevated. And we know that age of menopause is associated with your risk as well. So the later the menopause is, the higher the risk. Some things that we know from the evidence are not associated with ovarian cancer risk is alcohol consumption. The evidence currently suggests it's not really associated with ovarian cancer risk. Smoking is not really associated with ovarian cancer risk unless you look at a particular subtype of ovarian cancer called mucinous. That's a histological subtype where smoking is a risk factor. Talcum powder use is a very controversial topic. You may or may not have seen what's gone on in the US where Johnson & Johnson have been taken to the cleaners in the law courts where people have sued them for billions of dollars. That's based on the evidence that suggests talcum powder is associated with ovarian cancer risk. But a lot of that evidence has been based on case control studies, which we know have particular bias. From a scientific perspective, they are flawed. And the way in which you address that flaw is by doing a prospective cohort study where we address that question, looking at people into the future as they get ovarian cancer later. And with that prospective cohort study data, it suggests that talcum powder is not associated with ovarian cancer. So the best scientific evidence we have is it's not associated. We do have some risk factors that we know are protective. Things like breastfeeding, that protects against ovarian cancer. Age at first period is involved. Having children per child, as you have more children, that reduces your risk. And the oral contraceptive use reduces your risk as well. So these are some of the bits of evidence that we have the most scientific evidence for. So here's another question for you. Did you know that oral contraceptive pill use reduces ovarian cancer risk? This is a question on Mentimeter. That's interesting. So it's around about half and half. Oh, we have somebody with their raised hand. We'll come to questions at the end. So if you can write your question down on the chat, I'm sure we will be able to come to it. So yeah, it's about half and half. Some people know about this, some people not. I thought it would be worth showing you the evidence for that. So this comes from a very large collaborative analysis of all of the data. And basically the way you interpret this line, the blue line here is the relative risk for people who have never used the oral contraceptive pill. And the blue dots, this is the relative risk going down as you use the oral contraceptive pill for longer and longer. And as you can see, it's almost a linear trend, so that the longer, so if you've used the oral contraceptive pill at some point in your life for 10 years cumulative, your ovarian cancer risk will be about half that of someone who has never used it. So this is really interesting. If you were to think of it as a chemopreventive drug, it's actually very effective. at preventing ovarian cancer, and it's also very well tolerated. Obviously, there are things to consider whether you're taking it or not, whether or not you want to have children and things like that. So now we come to my area of expertise, which is epigenetics. Now, this is on Mentimeter as well, and you've got some questions. The question is, what is epigenetics? If you can write down what you think it is, we'll start to see a picture of what everybody understands about this word epigenetics. Switches, environment, and genes. Yeah, that's true. We'll give you a few minutes. There's a few people, there's about 20 people on Mentimeter, so we'll give this a second or so. DNA methylation, yes, that's true. Unfortunately, when you do it this way, there's a bit of positive reinforcement. If you haven't filled it out yet and you see these words popping up, you might type those words as well in agreement, so you can get a bit of positive feedback. Something with genetics, this is true. A layer of control on DNA, this is also true. Blood research, that's an interesting one. We certainly do our research in blood, but it's not just about that. Changes we can pass on, now there's a hot topic. That's an interesting question really, is about whether epigenetic patterns can be passed on from one generation to the next. We know that epigenetic patterns can be passed from one cell to another when it divides. That copying of epigenetic information is quite robust, but across generations could require an entire different webinar to discuss that. So I think we're getting close to the end of this. So the big thing there is environment. Yes, this epigenetics plays a part in, I guess, how your DNA interprets the environment and how it reacts to the environment. And you can see some of those other things. Genes, epigenetic patterns are things that sit on top of genes to interpret those genes. As somebody has written here, it's a layer of control on top of the DNA. And I'm not surprised to see somebody write, don't know, because even amongst the scientific community, there's a lot of people that still don't really understand what epigenetics is. So that's not surprising. But there's a lot of good points there, which is good to see. Right, so just to summarize that, what is epigenetics? It's about gene control. We know that DNA is packaged into your nucleus of all of your cells, and the packaging, the way it gets packaged, is controlled by epigenetic mechanisms. There are things that sit on top of the DNA that allow us to interpret that DNA. And an example here, you can have open chromatin, open DNA, where transcription factors can come in and do their job and make proteins, or if the DNA is packaged up really tightly, those transcription factors can't come in and do that job and can't make the genes. DNA methylation is one of the modifications on the DNA that controls that. So this is coming to our research and this research program and what we're trying to do. We have been, over the last 10 years or so, trying to understand what are the lifestyle factors that can influence your epigenetic patterns. And we've published on a large number of these topics, actually. Hormonal influences, so estrogen itself, we've shown can influence epigenetic patterns. Someone mentioned this idea of passing epigenetic patterns on through generations, and your epigenetic patterns can be influenced while you're in the womb. So there's a lot of studies, for example, that have shown if a mother is smoking while she's pregnant, then that epigenetic pattern associated with smoking can be detected in the child as much as 4 years later in their life. So that's an example of how an epigenetic trait can be passed on through what looks like generations. But it's directly exposed individuals. Diet can influence your epigenetic patterns. Smoking, I've just mentioned. Drugs can influence your epigenetic patterns. Alcohol, one of our favorite lifestyle factors, can certainly influence your epigenetic patterns. Aging, as we get older, our epigenetic patterns are diverging and changing and accumulating all of these environmental exposures that we come across throughout our life. And the one example I'm going to show you in a moment is about aging. We've also shown that tea consumption can influence your epigenetic patterns. as can BMI. Different BMI levels can influence your epigenetic patterns. So what we're trying to do in our research program is ask, of all these factors, how does that actually increase your ovarian cancer risk? And which out of all of these lifestyle factors are influencing your epigenetic risk of ovarian cancer the most? So that's what we're trying to address. And secondly to that, if we do find the ones that are influencing your risk, is there something we can do about it to reduce your risk and prevent ovarian cancer? So the one example I wanted to talk about is this idea of epigenetic age or biological age. A few years ago, this was from a publication in 2013, where this wasn't our work, this was somebody else that was doing it, showing that you can use epigenetic patterns detected in blood to calculate somebody's age or to predict somebody's age. And when you correlate that predicted age against their actual age, you can actually see it's a pretty good correlation. So our ability to predict somebody's age just from their epigenetic patterns is pretty good. It's about plus or minus 3 years that we can be accurate to. But what was really interesting in this study was the idea that some people are above this line, which means that this is an individual whose actual age is probably about 55, but biologically they look about 70. In other words, they're biologically older than their chronological age. In contrast, you've got other people who are on the other side of the spectrum who, this person is probably 65, but they've got a biological age of about 40. And when we were looking at this is data that comes from some of our breast cancer work, where we were looking at this and found that this epigenetic age was associated with breast cancer risk. And so it's probably not surprising, given that age is one of the biggest risk factors for all cancers, not just ovarian cancer. And if you're biologically older, then it probably stands to reason that your risk is at the level of that biological age, not your chronological age. And that's what we saw in breast cancer, and that's what we're going to be looking at in ovarian cancer. We will be getting the answers to that in the next 6 months or so. So just to come to the program and what we're hoping to do, this is the last slide I was going to present. We're asking, can we use these epigenetic risk factors to improve our risk prediction models? Can we use that alongside genetic risk factors to come up with a better, more accurate risk prediction? And we're some way along the way of getting the answer to that. I should say that we don't have all of the answers to these yet, and we haven't published any of our work on ovarian cancer just yet, but that will be coming soon. And we've got some ideas of what lifestyle factors are influencing epigenetic risk, and we'll be looking at those in relation to ovarian cancer risk. We've got some work ongoing that's using the oral contraceptive pill, and we're asking, how does that influence the epigenetic patterns? We've already got the answers that it is influencing the epigenetic patterns, but we're just trying to work out now whether those epigenetic patterns are changing are related to ovarian cancer risk or not. And if we can work that out, is there a way which we can make those same changes without having to use the oral contraceptive pill? Are there other drugs that we could use to do the same thing? So that's really the summary of the research that we're doing in this program. And as I said, we will be working on that in the next few years to come, and we'll be hopefully publishing some of those answers. So that's all I was going to present. I've got now here a Q&A slide, but I don't know if we want to go back to the chat, and I can stop sharing the screen if you wish. Let me know which you would prefer.
Thank you, James. That was so interesting, especially, there's so many environmental and genetic factors that can affect a woman's risk of ovarian cancer. So we're going to move on to some of the questions. We received a lot of excellent questions from the people that signed up. So thank you very much for anyone who sent one of those questions in. So we can start on those if you're happy, James, and then maybe move on to the Q&A.
Yeah.
Great. So I think the most common question was around, what are the main lifestyle factors that cause ovarian cancer, which you did touch on, but we did get a few specific ones. And one that I thought was really interesting was how large a part does high level of stress and anxiety play in getting cancer?
Yeah, that's an interesting question, actually. I was looking into this myself. And at the moment, there's not a lot of evidence that supports the idea that stress is involved in ovarian cancer risk. I did find a study that showed pretty conclusive evidence that post-traumatic stress disorder, PTSD, and the symptoms of that are associated with ovarian cancer risk. But if you're just talking about general stress or phobias and anxiety in general, the evidence currently suggests that it's not really associated with ovarian cancer risk.
Great, thank you. And someone else asked, is there a link between older pregnancy and a higher risk of ovarian cancer?
Yeah, so there's evidence for if you have children, that is going to reduce your risk compared to someone who doesn't have children, irrespective of what age you have that child. A later age of first birth has a very small effect on ovarian cancer risk, but it is one of the risk factors that is looked at. There's a lot of discussion about whether IVF and IVF drugs are involved with ovarian cancer risk, and I think the summary of the evidence so far is that it's not associated with ovarian cancer risk.
Great. And we also had a couple of questions around diet. For example, do you think there are particular foods that are more likely to cause an increase of ovarian cancer?
Yeah, this is a really tricky question, actually, because studying diet in relation to ovarian cancer risk, or indeed any cancer risk, is really tricky. And there's been a lot of epidemiology studies that have looked at diet, and so far there isn't evidence for any particular food type that is associated with increased or decreased ovarian cancer risk. I should say there's a lot of research that has looked at particular components, things like vitamin D or vitamin B, or folate levels, for instance, in relation to ovarian cancer risk. And currently the evidence is equivocal. There's no strong evidence for or against. You'll find some studies that show an association with risk and some that show that it's not. But when you put all of that evidence together and make a summary, the conclusion is that it's not a big risk factor.
Great. And then another popular question that we had, what changes in lifestyle factors could help prevent the recurrence of ovarian cancer? We had a few people asking that.
Yeah, this is an interesting question as well. And to be honest, it's not really my area of expertise looking at recurrence. There's another researcher, Bob Brown, who is at the OCA Research Centre, who looks particularly at this question. And with any luck, you'll get him on for a webinar soon. So you can ask him that question. But from my perspective, there's two ways to look at that. One is, are there drugs that we can be using as a maintenance therapy? And I know there is research going on to look at things like PARP inhibitors and whether or not they will be helpful as a maintenance therapy to prevent recurrence. The other way to look at it is, are there lifestyle factors or things you can do to prevent recurrence? And I think the summary is generally, it's what you've probably already heard: a good healthy lifestyle, healthy weight, exercise, and all of these things are beneficial. But how much of an impact they have on whether you get recurrence or when, I don't think there's really a strong case to be made for saying you must do this or must do that.
Yeah. So you talked a bit that you're doing some work around the contraceptive pill. And one of the participants asked, are you testing both the pill and the mini pill? And I think the mini pill, is that the progesterone only pill?
Yeah, I think that's right. And so one of the things I didn't mention there, obviously just to keep it simple, is a lot of the evidence is about the combined oral contraceptive pill. So that's estrogen and progesterone. And that's, I don't know too much of the evidence on progesterone only. I think it's also protective, but I don't know the levels of protection in terms of which one's better or worse. And I can see a question here on Mentimeter: is estrogen only protective? And the answer is, yes, it is. It is protective. But I don't know the levels of protection in terms of which one's better or worse. And there's, I can see a question here on Mentimeter: is estrogen only with the contraceptive pill? How does it work? Is it the lack of periods that reduce risk? Is it a lack of ovulation? I should say there is probably about 10 to 15 different hypotheses for why that might be preventing ovarian cancer. There's a lot of ideas that it's to do with inflammation, reducing inflammation, and how that influences the cellular environment and whether that prevents cells from becoming cancer cells. But I think the answer is that we don't know the answer to that question, and that's part of what we're doing our research for. We're trying to find out whether there's an epigenetic explanation for why oral contraceptive pill. And we're actually looking at both estrogen and progesterone, and we will be able to tease apart whether it's one or the other that's influencing the epigenetic patterns. So far, I've seen from our data that it looks like it's a combination of both.
Yeah.
That seems to be causing the biggest change for epigenetic patterns rather than one or the other.
Great. Should we move on to the next question on Menti?
Yeah.
Got quite a few there.
How do I, oh, Marcus answered. Here we go. Yes, so this question about early period, late menopause, both of those increase risk because it's in essence extending your exposure to estrogen or throughout your life. So both of those things are in essence increasing your risk. I think I'll mark that as answered. Use of IUD for over 20 years increased risk. That I don't know about. I don't know too much about IUD and how that increases risk.
Could that be linked to inflammation as well, maybe?
Yes. I guess anything that's linked to inflammation could well be associated with risk. Yeah, that's an interesting one. I don't know the answer fully for that one. What else? Have the ability, oh, this is a really interesting question. Do we have the ability to alter faulty genes like BRCA1 and BRCA2? Well, scientifically, we already have the tools, the genetic editing tools to be able to do that. We have something called CRISPR technology, which is able to make changes to faulty genes. And some people, I think, where was it, in China, I think, got into a lot of trouble for creating embryos and subsequently children who have had CRISPR to edit a gene that didn't really need to be edited. And there was a lot of controversy there. And that brings up really the most important question here is it ethically okay to use these technologies to change genes, particularly because we don't know the unintended consequences of that.
Yeah.
And so I think the answer to this question is we do already have the technology, but we don't have, I guess, the answers to the ethical questions yet. And that's a debate that should be had, I think. There are obviously other ways you can do genetic screening of embryos. If you're doing IVF, for instance, there's the ability to do genetic screening for faulty genes, and you can select the ones that have or don't have it. But yeah, it's an interesting topic, whoever asked that question. Let's move on. What's the most urgent question? Do you know what? I think it depends on who you ask that question to. If you ask an ovarian cancer patient, they will probably want to know what's the best drugs, how can we best treat those ovarian cancer patients to allow them to live much longer? Can we treat them earlier? My personal view is the way in which we will make the biggest impact quickest is whether we can diagnose patients earlier. If we can diagnose a patient 3 months earlier, 6 months earlier, then that will potentially make a really big impact. I think I showed a slide earlier that if you get diagnosed at stage 1, your overall survival to 5 years is 90%. If you're diagnosed at stage 3, it's down to about 15%. And so if we can diagnose those stage 3 patients at stage 2 or stage 1 earlier, then we make a much bigger impact on ovarian cancer, and we'll be able to do that quicker. And we do have some research in my lab that's hopefully going to help address that, but we're not talking about that one today. Right, let's move on. What have we got? Tested negative for BRCA1 or 2, or RAD51 genetics test. If you're tested positive. So RAD51 genes are interesting because they've been discovered much more recently. In the last 4 to 5 years, they've been discovered as ovarian cancer risk genes, a little bit like BRCA1 and BRCA2. The level of risk associated with RAD51 genes is less. It's I'm not sure the exact numbers. I think it's around about 8 to 10%. And if you do have positive tests for those genes, then obviously speaking to your GP or whoever's giving you the genetic counselling will be able to give you much better answers on what interventions are available or appropriate for those levels of risk. I don't think it's for me to say what treatments or interventions should be offered.
Great.
Why is that not mentioned as a risk factor? I guess it's not, potentially because it's not the most common of risk factors. I think we tend to talk about, I guess, is that a sign of symptoms rather than a risk factor? Risk factors we tend to talk about them as things that increase your chance of getting cancer. If you're talking about spotting as a sign of ovarian cancer, a symptom of ovarian cancer, then it's not a risk factor per se, it's a symptom. And we do talk about those 4 main symptoms of ovarian cancer, but they're not the only symptoms. I think you could probably, when I last looked at symptom questionnaires, it runs to about 10 or maybe 15 or 20 different symptoms that people experience as signs of ovarian cancer. So it's certainly one of those. All right, that's the same question.
We've got a really good question in the Q&A. Are there other genetic risk factors apart from BRCA that have been found now?
Yes, there's a couple of, so I mentioned this idea of polygenic risk scores. These are common genetic traits that everybody has, where we found about 38, I think maybe 40 different regions in the genome that are associated with ovarian cancer risk, that when we put all of them together into a model, we can use that model to predict somebody's risk. So what we don't know is which of those different genetic regions are associated with particular genes. It's really difficult to work that out. Some of them we know, some of them are more difficult. So we do know some of the genes that are associated with ovarian cancer risk. There are some other genes that are associated. There's I think a gene called PALB2, I think, which is associated with risk. It's a little bit like the RAD51. It's more recently discovered. And there's 1 or 2 other genes like that where the risk isn't nearly as high as BRCA1 and BRCA2, but is much more substantial risk than the general population. So yes, there are some other genes that have been discovered. But as with all of these things, a lot of those genes are quite rare to have those mutations. So generally, at this point, they're not generally screened for, although I think that is changing. There's panel gene testing going on to identify them. Is there any particular findings associated with mucinous ovarian? Mucinous ovarian cancer is a really interesting subtype of ovarian cancer because it's very different in terms of risk factor profile and in terms of histology and genetic profile as well. For instance, there's a particular gene mutations in genes such as KRAS, which you get in mucinous ovarian cancer that you don't get in all the other subtypes. And some of the genes that are frequently mutated in other ovarian, like serous ovarian cancer, that's the most common, in a gene called P53. You don't tend to get that as much in mucinous ovarian cancer, for example. So the genetics and the risk, I mentioned smoking as a risk factor. Oral contraceptive pill is an interesting one where it is a preventive agent for most ovarian cancer subtypes, but not for mucinous. So all of that evidence put together kind of suggests that mucinous ovarian cancer isn't really ovarian cancer. It might actually be, there is a school of thought that says it's um, a metastases from an other tissue, perhaps colon tissue, or a different type of tissue than ovarian tissue. But the jury's out on that. There's a lot of debate going on about that. And I think at the moment, it's still called ovarian cancer. It spreads around the peritoneum like ovarian cancer, and it gets treated as ovarian cancer still at the moment. And so from a scientific perspective, we tend to keep including it in our studies. And so that one, have we been able to test for general public that measures epigenetic risk of ovarian cancer? So this is exactly what we're working on at the moment. We don't have that test yet. Somebody, I think, was asking whether or not, how would we be testing this? The work that we're doing is mostly on blood DNA. So what we're working on would eventually become a blood test where we would take a blood sample and we could measure the epigenetic patterns in that blood sample along with the genetic patterns. And we can put that all together in a risk model that we would then be able to compute an individual level of risk. So that's how we would use that. So epigenetic risk isn't there yet. Genetic risk is being offered by some places, I think. I don't know if it's not offered on the NHS, and it's not generally used yet, but I think there is a way to get your genetic testing done, and you can include that into some online tools that can measure your risk of ovarian cancer. There are some good tools. There's one called CanRisk, CANRISK, which is led by a group up in Cambridge. It's based on what they call the Boadicea model, where you can input all of your information, and you can even input your family history, and that can give you a risk output for your own risk. But there's obviously a big caveat with that it's not a medical diagnostic tool, it's just a research tool, so you can't necessarily use it to make medical decisions or interventions. Okay. Grandmother had ovarian cancer early 60s, but mother hasn't, diagnosed at 36. Should they be concerned? So if you've been tested for BRCA and you're negative, then there's a very strong chance that your mother and your sisters and her sisters are negative as well. And there's a very good chance that your grandmother got ovarian cancer in the 60s. That's the average age that most women get ovarian cancer, and they could be 2% of the population. Getting diagnosed at 36 is very young for ovarian cancer. And so that would be an indicator of a potential genetic trait. As I mentioned, you might be BRCA negative, but you might have a RAD51 mutation, for instance, that puts you at higher risk. It might be worth having that conversation with your GP to talk about whether or not that's worth testing, or whether it's worth finding out. But I think, as with all statistics, if you say 2% of the population and 2 people out of 100 have ovarian cancer, then that's 2%. To have 2 people in your family, that puts, if you've got your family, if you've got one of your members of your family, that puts you at higher risk already. So your risk would have been about 4%. And so that's the chance of getting ovarian cancer. But as I said, at a young age, it's probably worth that discussion about whether other genetics might be involved. Okay. Not NED. I'm sorry, I don't know what NED means. No evidence of disease. Is that what that means? Is PARP inhibitor cost effective? So I think, as I mentioned, it's under review in a research setting, in clinical trials and I guess research studies trying to understand whether it would be of benefit to use PARP inhibitors as a maintenance therapy. It's not standard of care at the moment because the evidence isn't there yet. So it's difficult to say at this point that it is something worth doing because we don't have the evidence to make that judgment. But if you're concerned about it, then it's worth talking to the oncologists that you see. I think there's no harm in asking about that. Is there a difference with factors for low graders that is usually diagnosed in younger women? So risk factors. So I was looking at this a few months back, looking at whether or not there's a difference in all of the lifestyle risk factors for low grade ovarian cancer compared to high grade. And a lot of the risk factors are pretty much the same. There is a difference in the point estimate. So in other words, how much of an impact it has on risk is slightly different. But the things that are often risk factors for high-grade ovarian cancer are often also risk factors for low-grade ovarian cancer as well. That could be BRCA negative, but the tumour could be BRCA positive. Can that happen? That would be remarkable. But I think it probably has happened. It does happen. If you think about your ovarian cancer, tumour DNA gets mutations in lots of different genes. You will it's what we call somatic mutations. So these are mutations that happen in the tumour but do not happen in the rest of the cells of your body. If you're BRCA negative, if you're BRCA positive, you will have that mutation in all of the cells of your body. So if you're BRCA negative, you don't have that mutation in your tumour to start with, but as the mutations accumulate, it's possible that you could get a mutation in a BRCA gene. And I would say if that happened, that would actually be probably good news. Because one thing we probably haven't touched on is that if you're BRCA positive, generally you respond to platinum treatment really well. You would certainly respond to PARP inhibitors really well. And these are the treatments that are being considered for ovarian cancer. So as I said, it's probably very unusual if that did happen. But if it did, it would be potentially good news. Okay. Speak up if there's anything in the chat, because I'm not keeping an eye on the chat. I'm just going through this.
There is a really interesting question in the chat that I'm quite interested in as well, but can we be tested for biological epigenetic age? It sounds quite scary.
So yes, I think there are some companies that are starting to offer this as a potential test. I don't think it's widely used. There's actually a study, I think it's based at UCL, called the Personal Genome Project that you can enroll in. I'm not sure whether you have to pay to enroll in that or not, or to participate. But they do a whole suite of genetic sequencing and epigenetic characterization, and they can offer the epigenetic age, I think, in that test. There are probably companies that are popping up that can offer this. I haven't really kept an eye on what companies are offering that. But yeah, I guess my question is, what would you do with that information once you...
Yeah, I'm not sure I would want to know mine, but
it's a debate to be had about any risk modelling, actually. Would you really want to know? And I think this is a really important question about risk prediction. At what age would you like to get your risk predicted? My personal view is you would need to do it young enough, at which point you can have intervention that makes sense to prevent you getting cancer at a later age. So for instance, let's imagine a situation where you're 20, 25 and you get your ovarian cancer risk, and that suggests that you're slightly high and you could bring that risk down by using the oral contraceptive pill for the next 5 years. You might choose to do that. Obviously, if you're at 50 and you get your risk, that option might not be available, or it might be too late to do something about your risk. Also, if we see that, by maintaining a lower weight, you can reduce your risk, then it's far better to have done that at a young age and maintain that for the next 20 years, rather than at the age of 55 think, oh my goodness, I've got to lose weight. Of course, it's still a good thing to do, but it won't change your risk as much.
Yeah.
Yeah. How does our research get trickled out to GPs? It takes a very long time. I think if I can use the genetic trait example. So we've been studying these common genetic traits since about 2005. So for about 15 years, we've been investigating these traits. And we have a pretty good genetic model for risk now, but it still hasn't made it into the GP offices and the clinics in the NHS. It's not offered as standard practice. Now, that's partly because we don't have as much evidence as we would need to prove that it's worth it financially, and I guess the health benefits have to be worth it for the NHS to spend the money on it. And so that has taken a very long time for that information, and it's still not there yet. So with our epigenetic information, when we do discover things that we want to incorporate into that model, it will take probably a similar length of time, hopefully less, but I'm afraid these things take a long time.
Yeah.
Yeah, that's, I think, something to be discussed with GPs. If a relative had, is that the same for non-BRCA positive? Yes, so that information about relatives is related to, potentially a little bit related to BRCA mutations and other genes that we know about, but also these common genetic traits. So you will have those same, very similar pattern of common genetic risk as your relatives, sisters or mothers that had ovarian cancer. And so that's why you're at an elevated risk compared to other people that don't have those same genetic traits. Oh, some of the ovarian cancer risks for Lynch. So Lynch syndrome is a syndrome that's associated with a particular gene mutation in genes such as a gene called MLH1, MLH2, MSH2. These are genes known as mismatch repair genes. These are DNA repair genes. It's far more common for Lynch syndrome patients to have colon cancer. It's much more common, but they do also get ovarian cancer as well. Part of the reason is that those mismatch repair genes are also important drivers of ovarian cancer. So if you have the Lynch syndrome, you are at a much elevated risk of ovarian cancer as well. Can you test negative for BRCA, but your tumor be positive? I think we've answered that. That was a question earlier. Do infections in the gynecological region increase ovarian cancer risk? Mucinous ovarian cancer. So this is something that's not really my area of expertise. I don't know. As I said earlier, I think inflammation has a role to play in ovarian cancer risk. So if infections lead to inflammation and inflammation lead to increased risk, that's possible. As I said, endometriosis is certainly one of the bigger risk factors for ovarian cancer. But in terms of infections, I don't know of any evidence that really suggests that.
Great. Well, I think that's a really good place to leave it there. We got through so many questions. They were really interesting questions as well. So yeah, I think we'll wrap up the webinar there, and thank you for all of you for joining our session today. We really appreciate your interest and support, and a massive thank you to James as well for taking the time out of your very busy schedule at the moment, I'm sure. That was so interesting, and this this webinar will be available for people to view afterwards, so lots and lots of knowledge and interesting facts to share there. We have many other sessions happening over the next couple of months, not just research webinars, so I'll send a link for you all to see what else is on. I'll also send out a post-webinar survey to see how you like the session and if you have any suggestions. So thanks again to everyone for joining today, and I hope you all have a lovely rest of the week. And again, massive thank you to you, James. That was really, really, really interesting. I really enjoyed that. And yeah, we look forward to seeing you at our next research update webinar.